Hello, I'm Mike Knoppen, the Program Director for the Myotonic Dystrophy Foundation. Welcome to this Ask the Expert series webinar on DM and the brain, or central nervous system. The mission of the MDF, a care and a cure, is to enhance the quality of life of people living with myotonic dystrophy, or DM, and to accelerate research focused on finding treatments and a cure. Our work focuses on support and education, research, and advocacy. You can find a number of resources and support opportunities at the MDF website, including our toolkits and publications, which you can find at myotonic.org/toolkits-publications, virtual support groups and Facebook chats at myotonic.org/find-support, a calendar of events at myotonic.org/calendar/month, and our digital academy, which includes not only recordings of other Ask the Experts series events and conference videos, but a number of videos from past series and events, all at myotonic.org/digital-academy. The Myotonic Dystrophy Foundation is pleased to join a global alliance in declaring International Myotonic Dystrophy Awareness Day on September 15th. But the campaign to raise awareness has already begun. Find tools and resources to join this great effort and to raise awareness about myotonic dystrophy in your community and online at myotonic.org/international-DM-day. You are joining the Ask the Expert series today, and this series continues on the third Friday of each month at 12 p.m. Pacific through August. Our last Ask the Expert series event will be August 20th, and that subject will be anxiety and DM. Then in September, MDF will be holding our annual conference, and we hope that you will register. Registration is already open. Ask the Expert will resume in 2022. You can register for future events and ask questions of Ask the Expert series speakers at myotonic.org/ask-expert-series. Another terrific series of the MDF is our Meet the DM Drug Developer series. This series occurs on the first Friday of each month at noon Pacific. Our next event will be August 6th, and we will hear from Avidity Biosciences. Then, again, our MDF annual conference will be held in September, at which time you will not only be able to interact with and meet drug developers, but hear updates from a number of companies working on drug developments. You can register for future events or view past sessions and submit questions at myotonic.org/meet-DM-drug-developers. If you have missed any of our past series sessions, don't worry about it. All of them are recorded, and they will be posted to MDF's Digital Academy. You can go to that Digital Academy to see this and other recordings at myotonic.org/digital-academy. If you have any questions about this series, past series, or other activities or events of the MDF, please contact us. You can call 415-800-7777 or email info@myotonic.org. We can't wait to hear from you. I'm very pleased to introduce our speaker for today's Ask the Expert series. Dr. Faisal Fecto is a board-certified neurologist and neuromuscular medicine specialist at Stanford University School of Medicine. Dr. Fecto studied medicine at the Aga Khan University in Pakistan, Northwestern University, where he also earned his PhD in neuroscience, the University of Iowa, and Stanford University. Dr. Fecto has received countless awards, including the Resident Teaching Award, Resident Team Leader Award, a resident lectureship by the Iowa Neurological Association, and a fellow scholarship by the American Academy of Neurology. Dr. Fecto is a well-published researcher and serves as an associate editor for the journal BMC Neurology. His research explores the pathogenic mechanisms that contribute to neuromuscular disorders such as myotonic dystrophy, as well as amyotrophic lateral sclerosis. Dr. Fecto is a member of Alpha Mega Alpha Honor Medical Society, Sigma Z Scientific Research Honor Society, the American Academy of Neurology, the American Association of Neuromuscular and Electrodiagnostic Medicine, Society for Neuroscience, and the American Association. We're very pleased to have Dr. Fecto with us, and you can welcome him in just a moment. This is indeed an Ask the Expert series, and we welcome your questions. A number of questions were submitted in advance, but you who are watching live can submit questions as well. Here's how. Go to the bottom of your chat box. Use the drop-down to select Send Question for Staff. Type the question and send it. You can practice now if you'd like to get used to it so that you know what to do throughout the presentation when you have a question. Again, you go to the bottom of your chat box, you use the drop-down to select Send Question for Staff, type, and send. Thank you all so much for joining this event live, and now please join me in welcoming Dr. Faisal Fecto. Dr. Fecto.
Thank you, Mike, for the kind introduction, and thanks everyone for joining. So today's talk is titled Myotonic Dystrophy and the Brain as the Expert. So I consider you guys to be the experts of this disease because you are dealing with this and providing care to patients with myotonic dystrophy. So when we talk about myotonic dystrophy, I should think of it as a rare neurological disorder, which it is compared to other disorders like Alzheimer's and Parkinson's and stroke. But really, it is the most common adult onset muscular dystrophy with an estimated prevalence of 1 in 8,000. As most of you are aware, there are two genetically distinct types of myotonic dystrophy. Your classic myotonic dystrophy type 1 and myotonic dystrophy type 2, which is generally milder and can have more variable clinical phenotype as far as expressivity of the symptoms are concerned. For both of these subtypes, the clinical phenotype can be variable, but for the most part does include skeletal muscle weakness and myotonia, which is impaired relaxation of muscles. There can be cataracts in the eyes, there can be cardiac conduction defects, as well as endocrine problems. And central nervous system involvement does occur pretty frequently and can cause cognitive deficits, excessive daytime somnolence and fatigue, apathy or reduced motivation, and impaired social functioning. And as I mentioned, these symptoms are actually pretty frequently reported by patients and may greatly impact several domains, like quality of life, relationships with caregivers, and engagement with the medical care. One thing to note here is that myotonic dystrophy does not cause an Alzheimer's disease type of dementia, and it does not really per se lead to brain degeneration or nerve cell loss, as is seen in a lot of neurodegenerative diseases. So when you look at patient-reported impact of central nervous system symptoms in myotonic dystrophy, you see a high prevalence of fatigue and impaired sleep or daytime sleepiness. And you can see up to 90% of patients themselves report an impact of these two symptoms. But also frequently, what is noted is a decreased performance in social situations, emotional issues, communication difficulties, a decreased satisfaction in social situations, and a difficulty with thinking. In this study, the authors asked patients with myotonic dystrophy several questions as relating to the health-related quality of life. And whereas certain things are not surprising, right? And scores closer to 100 mean good quality of life. And then you can see that across all domains, patients with myotonic dystrophy perform about the middle or even below. So physical functioning is obvious, with skeletal muscle weakness, you may imagine that impairing your quality of life as seen here. But what was also pretty common was things like social functioning affecting the quality of life as well as mental health. So the central nervous system manifestations can really impact quality of life in patients with myotonic dystrophy. Experts do recognize now the range of disabilities that are seen in myotonic dystrophy that are related to the central nervous system. These span the domains of intellectual as well as behavioral issues. So as far as intellectual issues are concerned, the most common, as I mentioned before, is fatigue and excessive daytime sleepiness. Intellectual disability only occurs in the congenital forms or those with very severe symptoms and does not really affect the vast majority of myotonic dystrophy patients. There can be learning difficulties, especially if a patient has disease expression as an infant, but also somewhat in the adult form. And then there's wide-ranging effects on the brain, as we'll talk about later in this talk, that lead to problems with the frontal lobe. And impairments here can cause a wide range of issues, including social difficulties, executive dysfunction, and visuospatial difficulties. And we'll dive a little bit deeper into these categories and explain what these are. Patients with myotonic dystrophy also can have difficulties with concentration, focus, and processing speed. And then when you look at the behavior, there can be apathy or poor motivation. There can be some personality traits like rigidity, impulsivity, and avoidance. Some passive aggressive traits have been reported, as well as some depression. So here, this questionnaire was administered to patients with myotonic dystrophy type 1, kind of asking about their experience with sleep problems. So you can see, again, the daytime sleepiness is by far the most common reported in patients with myotonic dystrophy, but you also see a common report of unrefreshing sleep, difficulty falling asleep, difficulty staying asleep, having a poor sleep schedule, and other things like nightmares or restless legs are less commonly reported in patients with myotonic dystrophy. So this, I apologize for this complex figure, but this is just to highlight the complex interplay. So let's tease these things out. So CNS just basically means the central nervous system. SDB is for sleep disordered breathing, which basically is a fancy way of saying breathing difficulties during sleep. And EDS is excessive daytime sleepiness. So there's an overlap of the symptoms as far as fatigue and excessive daytime sleepiness is concerned, because a person is sleepy during the day, then they also will feel more fatigued, and fatigue per se can also lead to excessive daytime sleepiness. So this kind of overlaps. And this concept is very easy to understand, that your muscle weakness or musculoskeletal symptoms can lead to fatigue, but also muscle weakness can cause problems with breathing during sleep, leading to sleep disordered breathing. And this can have an adverse impact on your central nervous system or the brain, and can lead to, poor ventilation when you're sleeping, so will ultimately lead to fatigue during the day or excessive daytime sleepiness. And then the brain also, over time, there can be an effect in certain individuals where dysfunction at the level of the central nervous system and the brainstem can also lead to abnormal breathing during sleep. And all these kind of have a interplay with each other. There's another way of looking at this concept. So again, when you look at sleep disordered breathing in myotonic dystrophy, you can have, as I mentioned, the weakness of muscles that deal with respiration, and that can cause difficulty with breathing during sleep. In addition, your upper airway muscles can lose tone when you're sleeping and can cause an obstructive apnea kind of a pattern. And that also leads to sleep related breathing difficulties. In certain individuals, with chronic disease, there can be skeletal deformities like scoliosis, and those structural deformities will also impair ventilation. And then, as I mentioned, in certain individuals, there can be an altered central nervous system mediated dysfunction of respiratory control, which also can cause sleep disordered breathing. And over time, your brain has chemoreceptors or receptors that measure how much carbon dioxide is in your system to kind of mediate expulsion of that. But in individuals with myotonic dystrophy, over time, the receptors tend to get adapted to these higher levels of carbon dioxide, so they can become hyper-responsive and lead to similar difficulties. When we look at now going into the different kinds of intellectual problems, since a lot of the dysfunction, and we look at MRI pictures showing this in detail, affects what we call the frontal lobes. Frontal lobes are very important in what is known as executive functioning. Again, a very complex concept. I'll try to break it down here into what executive functioning is. So it deals with things like impulse control. So, thinking before you act, or emotional control, keeping your feelings in check. And also is important for flexible thinking. So when you are posed with an unexpected event, how do you change your behavior to deal with that? Also important in working memory. So, if you're solving a puzzle and you have some information that you need to keep in mind, that is your working memory, that you can bring it up right away and use it to solve that puzzle. So those kind of things are also impaired. Self-monitoring, so to be self-aware of how you're doing in this moment, and planning and prioritizing to set and meet goals, for example, at work or at school or even at home. There can be issues with task initiation, so taking an action to get started on tasks. So, there can be procrastination. And as an organization, to keep track of things physically as well as mentally. So executive functioning, as you can see, encompasses all these different domains and are really vital to for processes that we usually take for granted. And these can all be affected because of the impairment of the frontal lobe in patients with myotonic dystrophy. Visual spatial function is also controlled by an area of the brain, including the frontal lobe, also the parietal lobes. And here, just to give you an example, all of us have had this issue going into IKEA and getting lost in the maze and trying to find, where we are going, either trying to find something or after we find it to get back to the checkout. And so this kind of something would, which you take for granted, would really challenge a patient with myotonic dystrophy. And then you take the furniture home, and now you have to open this DIY manual and try to, what starts in the morning, you're there all night trying to get this furniture fixed. So again, taking use not only of visual spatial function, but also your executive functioning. So all these chores can be pretty challenging for patients with myotonic dystrophy. So apathy is another complex concept. What it means is basically an I don't care kind of an attitude. And you can think of it in an affective manner, meaning, it includes emotional blunting, like a reduced emotional display to either a positive or a negative event, a loss of empathy, and an indifference to things. Uh, Behaviorally, it can cause social withdrawal. There can be loss of self-initiated behavior and conversation. There can be poor persistence in activities, and then you may require excessive prompting to perform or getting things done. And if you look at it cognitively, there can be lack of interest in routine and novel activities. There can be reduced curiosity and difficulty with planning and implementing actions to achieve any goal. And again, this is an aspect that is governed by the frontal lobe. So this paper does a really nice job of kind of trying to synthesize the impact of the central nervous system manifestations in the life habits of patients with myotonic dystrophy. So because of the issues I mentioned already, you can imagine, with an irregular sleep-wake schedule, that there can be a problem with maintaining good physical fitness and also mental fitness. There can be difficulty in many areas of personal care, difficulty with getting things done around the house. Very important, maybe issues with responsibility, like difficulty with budget management and taking care of one's life, difficulty with meeting family's demands, difficulty with things like motherhood or child education for the myotonic dystrophy mother, for example. And then poor follow-up in general, which reduces engagement with medical care and rehabilitation. There can be impacts on married life due to interpersonal relationship problems. There can be decreased social interaction and social isolation, as well as low levels of education have been reported or frequent unemployment has been reported. And then recreation can be affected because of the restricted interest and participation in leisure activities. In this paper, the authors do a really good job of posing open-ended questions to couples and try to gauge, the impact on living with myotonic dystrophy, and they come up with these 4 different areas that are commonly affected. So one leads to decreasing abilities. So, the answers that they got were there are many barriers, no power, no pep, no guts, and then patients tend to avoid barriers. I don't do that much. So this can have an impact on the partners of patients with myotonic dystrophy. The second area that they came up with was increasing burden. So if I did not do it, nothing happened. There's, again, executive functioning issues and apathy or reduced motivation. And again, this can have an impact for both as a couple. And then finding a mode together was another area. So this was dealing mostly with renegotiation of tasks and, giving each other freedom to do different tasks as depending on the level of impairments. And this can have, as you can imagine, impact for patients with myotonic dystrophy, for the partners, and for the couples as a whole. And the last area that they mention here is the lack of understanding. So patients with myotonic dystrophy have to deal with this. where even their family or extended family may not understand what they're going through, or what the disease entails, or the different milestones or the progression of the disease. They tend to be the experts and manage themselves. And even healthcare at most places may just be these different islands that are focused on different parts of the disease. And now at bigger centers like Stanford, we have the multidisciplinary approach where you get a one-stop shop of the provider, the physician, the therapist, speech therapy, occupational therapy, respiratory therapy, and physical therapy, all under one roof, as well as social work to deal with some of these issues, so patients don't feel like they're not being taken care of holistically. Now we'll dive a little bit deeper into what is going on in the brain at the molecular level, at the cellular level, and even as it grows at a gross level, to see how these abnormalities are leading to the behavioral and intellectual issues we just talked about. So this again looks pretty complex. Just ignore most of what's written here. This is just showing the structure of a gene. So any gene is composed of exons, and this would be any gene for any trait in your body. And exons are what transcribe or are translated into proteins. And usually a mutation in the exons causes an abnormal protein to be formed, and because of that abnormal or mutant protein, a disease is expressed. Myotonic dystrophy is a little different. The type 1 is caused by a repeat expansion of CTG, so 3 letters, but they're repeated multiple times. And this occurs in an untranslated region, so not in the exon, not where typical diseases show mutations. And then similar thing is true for myotonic dystrophy type 2, where it's a tetranucleotide repeat, where there are 4 letters of the genetic code that are abnormal, but again, they are repeated multiple times. And again, this defect also occurs in an intron, or a non-coding region of the DNA. So how does a mutation in a non-coding region of the DNA cause disease? Because we know that coding regions can cause mutations and lead to aberrant proteins to be formed, and that is a concept much easier and occurs routinely in most diseases. So once you have abnormal expansion of these repeats in a non-coding region of the DNA, so it has been described, now well described, that in patients with myotonic dystrophy, it leads to the expression of these long strands of RNA, which have a tendency to clump together inside the nuclei of cells. So on the top panel, you see an untreated cell, and here they have introduced these repeat expansions, and you see how the nuclear material tends to clump up to form these ribonuclear foci. What that does is it tends to sequester other proteins, innocent bystanders, if you want to say, like muscle blind or MBNL1. And this is the normal pattern of expression of MBNL1 in a normal cell. It's kind of all over the nucleus. And you can see with the expression of these expanded and abnormal repeats, it kind of gets sucked in or sequestered into these foci and cannot be available to do its normal function in the other parts of the cell. And because of that, it can have issues with its function. And the function of a protein like this is causing splicing of different other genes. And because of this, there can be abnormal splicing of those other genes. And then because those other genes are not working properly, they lead to different aspects of symptomatology and dysfunction that is seen in myotonic dystrophy. Another thing that happens at the cellular level in patients with myotonic dystrophy is an abnormal clumping or aggregation of the tau protein. This protein here, you can see in the brown staining, is abnormal. It is clumping within the neurons and then becomes visible. And just as a side, this is the same protein, one of the proteins that is also aggregating in a disease like Alzheimer's disease. So even though I said that this disease, the myotonic dystrophy, is not like Alzheimer's, it does not cause neurodegeneration or neuronal cell loss and does not cause dementia. At some level, to a minor degree, we do see this accumulation of the tau protein. And we are still trying to figure out what that does. Here to just put everything into context, we just talked about this neuronal aggregation of the tau protein. We talked about the RNAopathy, where the abnormal expansion can cause be toxic itself. So this abnormally expanded RNA, when it clumps, it can be toxic to the cell just by itself, or it can, like I said, sequester other innocent bystander proteins and prevent them from performing their functions and cause what is known as a spliceopathy or a splicing alteration, which can have even more wide-ranging effects by affecting several other proteins and not letting them have their function. And then it's a complex interplay of these three phenomena that lead to different symptoms that are seen in myotonic dystrophy, including neurologic symptoms, but also other things like diabetes or the metabolic syndrome and others. Now looking at the brain as a whole, so if you look at MRI from patients with myotonic dystrophy here, we're looking at myotonic dystrophy type 1 compared to healthy controls. And here, this is the total intracranial volume, so the entire volume within the skull. So there is not much difference between patients and healthy controls in as far as the space inside the skull being available is concerned. But when you look at the ventricles or the spaces in the brain that carry fluid or the cerebrospinal fluid, there's a marked increase in the size of these ventricles. And if you look at the gray matter and the white matter, so gray matter is, the neurons that have, where the cell bodies of the brain cells are, and the white matter is where all the pathways, connecting pathways to different parts of the brain and the spinal cord go. There's a large-scale volume reduction, as you can see, in both the gray matter and the white matter, and this probably also is feeding into the expansion of the ventricular space in patients with myotonic dystrophy, leading to more fluid in and around the brain. There is some relationship with age, so you can see that these are patients with myotonic dystrophy, and you can see that at there's a reduction of the gray matter volume. So lower volumes at higher ages and higher volume at lower ages. And same thing with the CSF volume or the fluid volume in and around the brain. There is more of that as the disease progresses. So as the disease progresses, you see reduction in gray matter volume and an increase in the CSF volume. If you look at the pattern of gray matter volume loss in patients with myotonic dystrophy, this figure does a good job of showing how widespread these effects are. So they affect, the frontal and the parietal lobes, also the temporal lobes. Also, there can be some subcortical volume loss. And here, this is looking at the white matter or the tracts, the gross volume of those areas. And again, you can see it's pretty widespread. It kind of occurs all over the brain. In addition to the gross reduction in volume in these areas, another feature that has been well established in patients with myotonic dystrophy is what we call white matter hyperintensities. So when you look at these brains under the MRI scanner, you can see abnormal white signal in the white matter of these patients. So really, the white matter forming the connections between different brain regions is affected. And when you look at it using techniques that look at microstructure of the white matter or these tracts, again, you see a wide-ranging impact in different regions of the brain. And this basically is translated as, at least structurally, based on these studies, we can say that there is an abnormal connection between important parts of the brain and leading to a lot of the cognitive dysfunction that is seen in these patients. This study looks at the results from functional MRI. So functional MRI looks at the connection between different regions of the brain, but it does not look at it like the data I just showed you in the previous slide, which was looking at structure. This is looking at different parts of the brain getting activated at the same time. So, which is an indirect way of saying that these regions of the brain are connected or disconnected and communicating with each other or not. So when you look at results from functional MRI experiments, you see the same pattern. You see that there is an area of frontal disconnection where there's reduced connectivity between regions of the brain that occur in the frontal lobes. And then there can be an increased connection between the parietal lobe and the cerebellum. Whether this increased connection is a compensation or whether it is due to the underlying disease are questions that still need to be answered. So I want to take a few minutes now and talk about the management of myotonic dystrophy, especially the CNS manifestation. So here, if we look at the consensus-based care recommendations for adults with myotonic dystrophy type 1, this is, from the neurology journal, their issue on clinical practice. This is what is as a guide to the physicians. So for the neuropsychiatric symptoms, physicians have been told to advise the patient that if DM1 is a brain disorder, that it can involve cognitive deficits and changes in cognition over time. Physicians are encouraged to include psychiatric and behavioral examination in their assessments and not just motor assessments or pulmonary assessments. Physicians are advised to consider getting a baseline MRI scan, again, just to kind of get a bird's eye view of the current state of affairs in a patient's brain. And also to have a low threshold for referring the patients with identified psychiatric or behavioral symptoms and those with late onset phenotype and the patient with cognitive complaints to mental health care professional for testing and follow-up. Because the patients may have a limited insight into these issues. So, as caregivers, as partners, physicians are taught to seek input from, the patient's family members. And it's something to keep in mind as a caregiver of a patient with DM1 to kind of look out for these things and be proactive. And also to keep in mind that certain individuals can have a late onset phenotype and can exhibit a faster decline in certain cognitive functions. So the consensus care-based recommendations, as far as the psychosocial symptoms are concerned, physicians should assess a patient's social circumstance in the household, Always consider and be aware of possible child neglect, because of the issues I mentioned. The children could be neglected. So to kind of provide social service and support for that, recognize the need for acute financial issues, be wary of unsafe driving or in unsafe or unsanitary home conditions. And like I said, social service providers do a good job trying to tease these issues out and being proactive and helping patients and their families. Of course, support programs are always great, and organizations like the Myotonic Dystrophy Foundation do a great job with a lot of these services. As far as the guidelines for symptoms of excessive daytime sleepiness are concerned, there are questionnaires like the Epworth Sleepiness Scale or any other similar standardized questionnaire can be used to assess patients' reported symptoms as far as sleepiness during the day is concerned. And then if, these screening questionnaires trigger then a reflex sleep study should be considered as well, and then during sleep studies, sometimes we measure things like the brain waves or EEG, breathing measures, or even limb movements during sleep. And really the idea is to rule out any kind of an obstructive sleep apnea due to loss of tone in the upper airway muscles or a central nervous system mediated sleep apnea, which is causing a sleep disordered breathing. And then if, we do identify issues with any of these tests, the recommendations are to refer the patient to a pulmonologist and or a sleep specialist. And, we should always question patients regarding alcohol or caffeine consumption, medications, sleep habits. So these are kind of things to keep in mind that can also affect sleep, in addition to the issues that a patient with myotonic dystrophy may already be struggling with. Another thing is, of course, very important is weak respiratory muscles. So we need to perform regular assessments of the forced vital capacity or spirometry with the patient sitting and laying down to kind of see how much of real breathing muscle weakness is contributing to this excessive daytime sleepiness. And if this is the case, then a lot of patients with myotonic dystrophy may need a BiPAP, or which is non-invasive positive pressure ventilation, and a referral to a pulmonologist to help manage that. And some patients may need a stimulant such as modafinil, if there is a central nervous system alteration that is causing excessive daytime sleepiness. And also some places offer cognitive behavioral therapy or behavioral therapy for apathy, and these help treat fatigue, and even with apathy or reduced motivation, some patients are prescribed stimulant, especially if the apathy is associated with an impairing level of fatigue and excessive daytime sleepiness. So there are several things that can be done to kind of identify these issues, and then get ahead of them and manage them. Down the line, some exciting developments over the last few years is with the potential for gene therapy, things like antisense oligonucleotides or morpholinos, which are basically genetic material which can be introduced into the, here in mice, but also potentially humans. And you can see, whereas the placebo did not have an effect on the distribution of these foci, when you give the medicine that, or the gene therapy that's targeted towards myotonic dystrophy genetic alteration, you see that there's a rescue of the phenotype, and this is in muscle cells. But then a similar idea applies to the brain cells. But with a lot of these techniques, the challenge with um, affecting the central nervous system is making sure that the gene therapy gets delivered or can get to the brain and the brain cells. And there are some challenges like the blood-brain barrier, which forms a barrier to some of these substances. But we're trying on making modifications to delivery systems so that they can effectively target the brain cells. More recently, there's been some exciting data with gene editing with the CRISPR-Cas9 system. Again, here work done in mice and looking at muscle cells, you can see that very precisely specific areas of the DNA can be edited, and the untreated cells have these foci, and the treated cells have a rescue. And if you look at the exact numbers, the fraction of the muscle cells with the RNA foci, the ones that were treated with the non-targeting vector have more foci, and then the one that was targeted for gene editing has a marked reduction in the number of these foci. So, and then of course, both of these works have also shown that this effect continues downstream. So not only the reduction of the foci, there is a reduction of sequestration of other proteins to these foci like MBLN1, and also there's a rescue of the downstream effects where previously there was aberrant splicing of other proteins and impairing those functions, like in ion channels. All those functions can be recovered. Here, I just wanted to mention a few slides regarding the ongoing trials. So one resource, an excellent resource is the Myotonic Dystrophy Foundation website, which lists a lot of the clinical trials going in the field. But I wanted to just put a plug in here for ongoing studies at Stanford. If anybody's interested, here's the contact information. One study relates to the central nervous system biomarkers, really looking at the cerebrospinal fluid. So this involves getting a spinal tap and looking at the RNA and the protein expression profile in the cerebrospinal fluid. And the exclusion criteria are use of blood thinners or patients taking benzodiazepines. Another study looking at the central nervous system is determining the biomarkers through EEG or brainwave recording and cognitive assessments and its impact on daytime sleepiness. And this is a one-time study visit and involves a 30-minute EEG recording or a brainwave recording and some questions regarding sleepiness and performance. And this is another study looking at biomarkers and clinical endpoints in myotonic dystrophy patients, and a little bit more comprehensive, and looks at disease progression over 2 years. And this is a treatment trial looking at this medicine, tidaglosib, in patients with myotonic dystrophy, but in the congenital form. So both children and adolescents. And for now, looking at efficacy and safety of this compound. So inclusion criteria are ages between 6 and 16 years, and clinical diagnosis or a positive genetic test. And then the patients must be ambulatory and able to complete the 10-meter walk-run test. And you have the contact information. So thank you, everyone, for listening. And now I can take some questions.
Thank you so much, Dr. Fecto. We do indeed have quite a few questions for you. Before I begin that, I just want to remind our incredible audience, whether listening as a recording or listening live, that many of the clinical guidelines that Dr. Fecto has gone through, not only for DM1, but for DM2, for the juvenile onset adult community and the congenital DM community, you can find these guidelines at myotonic.org/toolkits publications. That's myotonic.org/toolkits-publications. Dr. Fecto, we have received a number of questions, both from individuals with DM1 and DM2, asking about memory. Would you please expand on what we know about the effects of DM for both DM1 and DM2 on memory?
Yeah, so as I mentioned, the effect on memory is not as pronounced as one would expect in a disease such as Alzheimer's disease. The effects can be more subtle, like in terms of things like working memory. So kind of as one is taking in new information, and before it gets stored in regions of the brain, there may be an impairment with that process. So you may, in a situation where you have been given new information like new names or new phone numbers, or new appointment times, those may be difficult to just capture. But there is no real major effect on long-term memory as far as as one would expect in a disease like Alzheimer's disease, per se.
Thank you, Dr. Fecto. Related to this, would that include the symptom that many folks describe as brain fog?
Yes. So brain fog is a complex concept. We always try to kind of translate what the patients mean, and everybody means a different thing by this term brain fog. So I think part of it is fatigue, as I mentioned, due to your physical neuromuscular manifestations or the central nervous system manifestations, and then that causing the excessive daytime sleepiness, and the sleepiness itself causing fatigue, and kind of blending into what people may describe as a brain fog. In addition to the other issues with the hardware that I mentioned, there's wide-ranging issues with the connectivity, loss of brain mass in certain areas, and that affecting executive functioning and visuospatial skills. But really, not just the hardware, but this fatigue and excessive daytime sleepiness itself forming a fog over your meditation.
Thank you, Dr. Fecto. Could you say more about impaired social functioning, something you mentioned early on in the presentation? What exactly would that mean? Would it include isolation or other manifestations, impaired social functioning?
Yes. So impaired social functioning, involves things like emotional processing and social processing at the level of the brain. Again, different brain regions are important for that, not just your frontal lobe, but also your insula or the temporal lobe, and also the amygdala, which mediates these things. And what happens is, because of issues with loss of volume in those regions, or impaired connectivity of those regions, people or patients with these kind of dysfunctions can have difficulty with emotional processing. So, for example, looking at facial expressions and seeing, okay, is this person happy? Is this person sad? Kind of getting cues from those. Is this a threatening situation? Normally we get all these streams of information, and we process them, and then we deal in that social situation. So this can have, the disease can have significant impairments because of those domains, but also because of apathy. The general this issue with lack of motivation itself can cause a social withdrawal or a lack of interest in leisurely activities or doing social activities. So again, a complex issue where two things kind of blend together. So apathy or reduced motivation kind of feeds into abnormal social and emotional processing in the brain, and then the effect is the same. The effect is impairment with the social interaction and activities.
Thank you, Dr. Fecto. Would you elaborate more on how DM affects the brain and central nervous system in the congenital form of DM?
Yes. So the way to think of it, so I'm not a pediatric neurologist, I mostly deal with adult patients, but really so all of these, the way to really keep it simple is to think of the congenital form having a severe phenotype and occurring early, and then DM1 kind of being in the middle and kind of more milder compared to the congenital form, and then DM2 being even more mild and variable.
Thank you very much. We have a number of questions and they continue to come in. This is a very popular topic for our community. Another question we have is whether white matter lesions are caused by a lack or use of the disease process. So to what extent are those lesions being caused by the process? And I think there's also a question of how might that progress over the course of life with the disease?
Sure. So, there is a lack of data as far as longitudinal studies are concerned in patients with myotonic dystrophy. Most of the studies that they've looked at is cross-sectional, which basically means a single time point in an individual with myotonic dystrophy, and then looking at different individuals at different ages, and then trying to kind of extrapolate that and trying to look at severity in that sense. But that's a little tricky because one individual may start with a different disease burden in the brain and may progress differently using that baseline. But right now we are comparing different patients at different disease stages and then trying to kind of extrapolate. So I think and these studies are relatively expensive to perform, and again, to get like a long-term follow-up for a slowly progressive disease like myotonic dystrophy, again, becomes challenging. So, is a 2-year follow-up meaningful, or is it 5 to 10-year follow-up meaningful to really track the changes as they happen longitudinally? But what is obvious is that there are these changes, and there is a correlation with age and disease severity, and how the basic disease mechanism is affecting, especially the white matter tract abnormalities, is intense area of focus right now. But it is very apparent that there is this problems with connections of important parts of the brain that cause a lot of these symptoms we talked about, but how it is mediated at a cellular level is still being deciphered.
Thank you, Dr. Fecto. And I know that we're just about at time. I wonder if we could ask you 2 more questions.
Oh, yeah, please.
We have a number of questions related to understanding the connection between both DM1 and DM2 and serious psychiatric disorders such as paranoia, schizophrenia, or psychosis. Can you speak about that?
Yeah, so, there can be some personality traits, like a paranoid personality, but per se, that have people have talked about in terms of patients with these conditions. But per se there is, a psychosis or schizophrenia as a disease entity. I don't think there's a disease association with myotonic dystrophy per se. So I have limited background in that because I'm not a psychiatrist, but from what I've read, at least, that patients could have certain personality traits that kind of maybe reminiscent of some of these, personalities. But per se, the disease of schizophrenia or psychosis itself, there's no disease association.
Thank you so much. And here's our final question for you for now, which is, do you have any advice for individuals who see a mental health professional, either a psychiatrist or a psychologist or a counselor, how to educate those mental health professionals about a diagnosis of DM, and what would be helpful for a patient of yours, for example, to say to such a professional to help them understand what they're dealing with so that the mental health professional can really be a part of the care team?
Sure. So yeah, I can completely understand. So some things we take for granted at like major academic institutions is that, we're lucky to have providers who are very subspecialized, and because of the nature of our jobs, we are kind of more exposed to having psychiatrists who may have more experience in certain areas than others, but out in the community, this is a challenge. So, you educate them just like you educate yourself, so referring them to like resources that foundations like Myotonic Dystrophy Foundation have, or looking at the consensus guidelines. Either you can find them online or encourage them to look for these. But there's been a lot of work in terms of description of the different personality traits or different comorbid psychiatric or psychosocial issues that occur in myotonic dystrophy has been well written about, and then there are guidelines on how to manage them. So it's just a matter of kind of educating them, and then the provider taking a little bit of initiative and getting educated about those issues, and then also, you have to continue being the expert. You have to kind of take charge of your own health. What I tell patients all the time is that you're responsible for your own health. If you don't care or you don't identify, and this is for patients and their caregivers, is, it's difficult to get a physician sometimes to notice these things, especially out in the community where they may not be aware of a lot of things just because of the rarity of the condition and the lack of their experience in those areas.
Thank you so much. Dr. Faisal Fecto is a board-certified neurologist and neuromuscular medicine specialist at Stanford University School of Medicine. You can re-watch this recording once it is posted to our digital academy at myotonic.org/digital-academy. And you can learn more about many of the topics Dr. Fecto has covered today at the Myotonic Dystrophy Foundation website, myotonic.org. And you can ask us additional questions at info@myotonic.org. Dr. Fecto, thank you so much.